All right, so just let me just give me a thumbs up if I'm audible to everyone. All right. Yes, so am I audible to everyone? Yes, very good. So yes, Adarsh, Soni and Chandia, good evening. Right. Very good, excellent. So now let us start with the session of, or we will continue with the clinical based questions of the endocrinology. So yesterday we were discussing endocrinology. So let me continue the same thing today as well. So I have said you that this month, all the clinical based questions will be related to endocrinology. Right? All the clinical based questions will be related to endocrinology. Okay? And next month, you will be having session on the clinical based questions on neurology and as well as cardiology and pulmonology. Right, and pulmonology. Okay, so this will be for the next month. Now, so let us continue with the endocrine session, endocrine questions like what we were discussing yesterday. Right, I hope everyone has enjoyed the session yesterday. So now we will continue with the same pace. Right, so you take the first question of the day. Right. Yes, this is the first question. A 65-year-old woman complains of panic attacks. She has recently retired as a school teacher, but 2 to 3 times a week, she suffers extreme anxiety, becomes shortness of breath, and sweats excessively. Elevated catecholamine levels are detected in the urine. What is the most appropriate medical treatment? Phenoxybenzamine alone, propranolol alone, phenoxybenzamine followed by propranolol. Fourth option, sodium nitroprusside, propranolol followed by phenoxybenzamine. Yeah, Gayaz Mohammed, I don't know why the screen is little blurred. So what do you want to give here? But I hope everyone is able to read the question. Very good. So the answer to this particular question is the phenoxybenzamine, right? Phenoxybenzamine followed by the propranolol. Okay. So now what is, can anyone tell me what is the diagnosis of this patient? Yes. What is the diagnosis in this particular clinical case? Any one of you? So diagnosis, definitely it is pheochromocytoma. So in pheochromocytoma, the treatment of choice, right? Very good, Chandia. The treatment of choice is surgical resection of the tumor. Right? The treatment of choice is surgical resection of the tumor. But before doing the surgical resection, right? But before doing the surgical resection, you have to maintain the blood pressure to less than 160 by 100, because in pheochromocytoma you will have increased blood pressure. So you have to reduce the blood pressure to less than 160 by 100. Now, in order to reduce the blood pressure to 160 by 100, what you need to give is, first you give alpha blocker. Right? First you should give alpha blockers. Then followed by that, you need to give the beta blockers. Right? Then you need to give the beta blockers. Now you take your phenoxybenzamine. Phenoxybenzamine, it's an alpha blocker. It is an irreversible alpha blocker. Okay. And always remember, you should never give the phenoxybenzamine alone. You should never give the propranolol alone. Or you should not give beta blockers first and then alpha blockers. You should never do that. Always alpha blockers first and then followed by beta blockers. Why? The answer is why. Sorry, the question is why. Let me explain you the reason. So, for example, if you block the beta first, right? If you block beta receptors first, then in such case, what will happen? There will be unopposed alpha receptors get activated. Right? So when there is unopposed alpha receptors being activated, the blood pressure becomes very high. Right? Unopposed alpha receptors get activated by the catecholamines in pheochromocytoma. Normally, whenever the catecholamines are released, few of the catecholamines will go to beta and few of the catecholamines will go to alpha receptors. But if you are blocking the alpha first, if you are blocking the beta first, what will happen? Once you block the beta, all your catecholamines will go and attach to the alpha receptors, and there will be unopposed increase in the blood pressure of the individual. And that will be more problematic than compared to that of pheochromocytoma. So never give beta blockers first. Always alpha blockers, then followed by the beta blockers. Okay. Now coming to the role of the sodium nitroprusside. Sodium nitroprusside, it is just used only in patients with aortic dissection. And even in aortic dissection, it is not being used very commonly nowadays. Why? Why the sodium nitroprusside is not being used? Why? Because this particular sodium nitroprusside, it will release cyanide, and that can make the individual death. So that is a very severe adverse effects with the sodium nitroprusside. And not only that, this sodium nitroprusside, it will cause rapid fall in the blood pressure. Right? It will also cause a very rapid fall in the blood pressure. And that is the reason why sodium nitroprusside should not be given. Right? So the answer to this particular question is what now? That is phenoxybenzamine, which is an irreversible alpha blocker that has to be given, and followed by that the propranolol has to be given, which is the beta blocker. Okay. Now because this is a pheochromocytoma, right? Now because the diagnosis in this patient is pheochromocytoma, can anyone tell me what is the investigation of choice in these patients? Yes, what is the investigation of choice in patients with the pheochromocytoma? So I'm just waiting for the answer. Who will tell me first? What will be the investigation of choice? So investigation of choice in these patients will be, anyone? So you have to do a 24-hour urinary catecholamine levels. Right? 24-hour urinary metanephrin levels, which are nothing but metabolites of the catecholamines. Okay. And what is that metanephrin you have to do? You have to measure the VMA. You have to measure the VMA. Vanillyl mannalic acid has to be measured. Right? And you take the normal value. Normal vanillyl mannalic acid value is less than 6 milligrams per 24 hours in urine. This is the normal value. So this can be asked in your exam. Please remember this. Right? This can be asked in your exam. So please remember this. Okay. So this is the clinical question related to your pheochromocytoma. And yesterday only I have asked you already. Can anyone tell me what is the most common symptom of pheochromocytoma? What is the most common symptom and what is the most common sign of pheochromocytoma? Yes, what is the most common symptom? Most common symptom of pheochromocytoma is headache, right? Very good, Chandya. And most common sign will be hypertension, right? Most common sign will be hypertension, right? So this is like most common symptom and as well as most common sign in pheochromocytoma, right? Next, then followed by that, we will move on to the next question. Yes, this is another very interesting question, and let me see how many of you can answer this question. We have a 39-year-old man presents with 3-month history of depression, right? Presents with 3 months history of depression. The patient recently lost a family member and around the same period began to feel unwell with constipation and a depressed mood. He has started taking analgesia for a sharp pain in his right lower back that often radiates towards the front. What is the most appropriate investigation in this patient? Serum parathormone, serum thyroid stimulating hormone, colonoscopy, fasting serum calcium, MRI scan. So what is that you want to do in this particular patient? Yes. Okay, so Shankar Deepu said serum thyroid stimulating hormone. Any other answer? Okay, Chandia says A. So every one of you are rotating around A and B. Okay, but out of that, finally, Bachu Prashanti. So Bachu Prashanti, you have answered it correctly. Very good, Bachu Prashanti. So the answer is the fasting serum calcium. The answer is fasting serum calcium. That is the answer in this particular patient. Okay, now let me explain you why. Right, let me explain you why. Now, all these clinical manifestations, right, all these clinical manifestations, whatever has been mentioned in your question, can anyone tell me what is the diagnosis here? All these clinical manifestations are secondary to anyone? So who will be the first person to tell me the diagnosis? You can tell me differential diagnosis as well. This particular patient is having what is called as hypercalcemia. Right, hypercalcemia. So hypercalcemia is the one which is giving rise to all these clinical manifestations in the individual. And let me tell you what are those clinical manifestations. So in hypercalcemia, these individuals, they can have constipation. Right, in hypercalcemia, these individuals, they can have depression. And in hypercalcemia, they can have a very sharp pain in the right lower back that often radiates to the front. What is this suggestive of? This is suggestive of renal calculi. And why is this renal calculi formed? This particular renal calculi is formed secondary to your hypercalcemia. Right? Secondary to your hypercalcemia. So that is what is your renal calculi. Now, in this patient, first you need to measure the fasting serum calcium. That will be elevated in these patients. So can anyone tell me what is the normal serum calcium levels? Any one of you, please? What is the normal serum calcium levels? Yes. What is the normal serum calcium levels? Normal serum calcium levels, they are around 9 to 11 milligrams per deciliter. That is the normal serum calcium levels. Very good, Adarsh Soni. Now, definitely there is increase in the serum calcium in these individuals. But for increase in the serum calcium, right, for increase in the serum calcium, there are multiple etiologies. Right, there are multiple etiologies. That could be due to increased intake of the calcium. That could be due to excess parathormone secretion. So, but first of all, you need to make out what exactly is the underlying clinical manifestation is due to. And later on, you can check, right? Later on, you can check the serum parathormone. Like that is later. But initially, it is the fasting serum calcium. And later you check for the serum parathormone, is it an etiology? Because in hyperparathyroidism, there will be increase in the serum calcium. Right? In hyperparathyroidism, there will be increase in the serum calcium. Right? So, we don't know. In this patient, is it due to hyperparathyroidism? We don't know. But definitely this particular clinical picture is due to your hypercalcemia. So the reason why you have to, so that is the reason why you have to do fasting serum calcium. Now you take the colonoscopy. Why you have to do colonoscopy if at all in this patient? In order to look for what is the reason for constipation. Right? What is the reason for constipation? But in this patient, it is not just only constipation he has. Along with the constipation, he is also depressed, and there is also presence of renal calculi. And how can you tell that there is renal calculi in this patient? Because there is sharp pain in the right lower back that is radiating to the front. That tells that there is renal calculi in the patient. So colonoscopy is not required in these individuals. And then TSH. Thyroid stimulating hormone. See, serum thyroid stimulating hormone, what it will do, it will increase T3 and as well as T4. So whenever there is increase in your T3 and T4, the individual will have diarrhea but not constipation. Or you take in patients with hypothyroidism. In hypothyroidism, they can have, right. So in hypothyroidism, they can have constipation. But the point is that in hypothyroidism, they will not have renal calculi. Right? There is no renal calculi in hypothyroidism. So that is the reason why, measurement of the serum TSH, right? That is the reason why measurement of the serum TSH in this patient will be of no value. Right? And why you want to do an MRI scan? Not required. MRI scan you have to do if there is any pathology to look in the spine. But the pain which is there in the right lower back is not due to pathology in the spine. The pain in the right lower back is mainly because of the renal calculi. Right? It is mainly because of the renal calculi. Okay. So that is about this particular clinical question. So what is the answer here? It is hypercalcemia. Now, can anyone tell me what is the treatment for hypercalcemia? Anyone of you, please? What is the treatment for hypercalcemia? So hypercalcemia, you have to treat by doing diuresis. So you have to give normal saline and furosemide has to be given. Right? Furosemide has to be given. So this is the treatment for your hypercalcemia. Okay. Now, for suppose if this particular hypercalcemia, if it is secondary to hyperparathyroidism, if it is secondary to hyperparathyroidism, then we give bisphosphonates. Can anyone tell me why you want to give bisphosphonates? Yes. Can anyone tell me why you want to give bisphosphonates? Let me explain. See, in hyperparathyroidism, what will happen? There will be increase in the osteoclastic activity. Now, what does this osteoclast will do? These particular osteoclasts, they will cause bone resorption and thereby increasing the calcium. Right, thereby increasing the calcium. So when you give bisphosphonates, what these bisphosphonates will do? Bisphosphonates will inhibit or reduce the bone resorption. Right, will inhibit or reduce the bone resorption. So that is the reason why you need to give bisphosphonates in these individuals. Right, that is the reason why you need to give bisphosphonates in these individuals. So in hyperparathyroidism, if it is causing hypercalcemia, you give bisphosphonates. Okay, so what are those bisphosphonates? Example, like you have alendronate, pamidronate. So the bisphosphonates, what we have is pamidronate and then alendronate, and then we have zoledronic acid. Right, then we have zoledronic acid. Okay, and what is the most common cause of hyperparathyroidism? Can anyone tell me? What is the most common cause of hyperparathyroidism? That is parathyroid adenoma. Right, most common cause of hyperparathyroidism is parathyroid adenoma. Okay, so that completes the discussion of this particular clinical question. Okay, so what is that you have to measure in this patient? You have to measure the serum calcium levels. Right, so this is another very interesting question. We have a 47-year-old woman complains of weight loss. Right, you see the age of the patient. Age of the patient is 47 years. Okay, and what is she complaining of? She is complaining of, yeah, very good Sankardeepu, excellent Sankardeepu. So the most common cause for hyperparathyroidism is parathyroid adenoma. So Sankardeepu has answered that, very good Sankardeepu. Okay, so now coming to this clinical question, we have a 47-year-old woman complaining of weight loss. She has a family history of type 1 and type 2 diabetes mellitus, but has never been diagnosed herself despite the findings of islet cell antibodies. You see here, she is also having islet cell antibodies in her, right? And family history is positive. Family history of type 1 and type 2 diabetes mellitus. In the last few months, however, she has noticed progressively increasing polyuria and polydipsia. And there is also 5 kg of weight loss. There is also 5 kg of weight loss. Her fasting plasma glucose is 8 millimoles. 8 millimoles means 142 milligrams per deciliter. That is what is your 8 millimoles. And urine dipstick shows the presence of ketones. What is the most likely diagnosis in this patient? Yes, what is the most likely diagnosis in this patient? Type 1 diabetes mellitus, non-ketotic hyperosmolar state, type 2 diabetes mellitus, occult malignancy, latent autoimmune diabetes of adult. Yes, so I'm waiting for the answer, and who will be the first person to answer this question? Let me see. Wow, very good. So Santhya Veer, right? Santhya Veer has answered this. Very good, Santhya Veer. The answer is E. That is LADA. That is LADA. Latent autoimmune diabetes of adults. Latent autoimmune diabetes of adults. That is the answer to this particular question. Now let me explain why. Let me explain why, and I will also rule out the other options. I will also rule out the other options. See, this particular latent autoimmune diabetes of adults, we call it as type 1.5 diabetes mellitus. This term is not usually used, but we call it as type 1.5 diabetes mellitus. Now, why is it called type 1.5 diabetes mellitus? Let me explain. So I'll just summarize the clinical scenario. Family history is there, 47-year female, islet cell antibodies are positive, polyuria and polydipsia are there, and urine dipstick showing the presence of ketones. Urine dipstick is showing the presence of ketones. Okay, now, so let me explain you about the LADA, latent autoimmune diabetes of adults. See, latent autoimmune diabetes of adults, that means what? It is seen in elderly individuals. Okay, next. Autoimmune, that means what? Autoantibodies are found. So autoantibodies, they are seen against the pancreatic islet cells. Right, they are found or they are seen against the pancreatic islet cells. Okay, so these are called as islet cell antibodies. Right, these are called as islet cell antibodies. So this particular clinical scenario is nothing but your LADA, latent autoimmune diabetes of adults. Now the question is, how do you rule out the other options? Right? How do you rule out the other options? You take in type 1 diabetes mellitus. In type 1 diabetes mellitus, the age group at which you see is less than 20 years. Right? Type 1 diabetes mellitus, the age group at which you see is less than 20 years. In type 1 diabetes mellitus, right? In type 1 diabetes mellitus, you will have the presence of autoantibodies. Right, you will have the presence of autoantibodies, but the age is what? Age will be less than 20 years. What is the age of our patient? Our patient age is 47 years. So this will rule out type 1 diabetes mellitus. Right, this will rule out type 1 diabetes mellitus. Okay? Then why not type 2 diabetes mellitus? Why not type 2 diabetes mellitus? Because the pathophysiology in type 2 diabetes mellitus is that it is insulin resistance. Right, it is insulin resistance. In type 2 diabetes mellitus, there is no autoantibodies. Right, there are no autoantibodies in type 2 diabetes mellitus. So please remember that. But in our question, what is mentioned? In our question, it is mentioned that there is presence of the autoantibodies. Islet cell autoantibodies are there. So that is the reason why your type 2 diabetes mellitus is ruled out. Right, type 2 diabetes mellitus is ruled out. Now you take the other options. You take the other options. So type 1 diabetes mellitus gone, type 2 diabetes mellitus gone, and in occult malignancy, there will be weight loss, but they will not have, there is no polyuria, right? And there is no polydipsia. So that is the reason why your occult malignancy is ruled out. That is the reason why your occult malignancy is ruled out. Whereas non-ketotic hyperosmolar state, this we call it as HONC, hyperosmolar non-ketotic coma. What is this hyperosmolar non-ketotic coma? The sugars, they will be in a range of 600 to 1200 milligrams per deciliter. Right, the sugars will be in a range of 600 to 1200 milligrams per deciliter. And ketone bodies will be absent. Right, ketone bodies will be absent in these patients with the HONC. Right, in patients with the HONC, the ketone bodies are absent. So now, but what is mentioned in our question? In our question, it is mentioned that urine dipstick shows the presence of ketones. Urine dipstick shows the presence of ketones. So that is the reason why your non-ketotic hyperosmolar coma is ruled out. And where do you get this non-ketotic hyperosmolar coma or HON? This is very common in type 2 diabetes mellitus. Right, this is very common in type 2 diabetes mellitus. So that is the reason why your non-ketotic hyperosmolar coma is ruled out. Occult malignancy is also ruled out. So the only option which is left out is your LADA, latent autoimmune diabetes of adults. Now, can anyone tell me what is the treatment for LADA? Yes? Any one of you, please. What is the treatment for LADA? I'm waiting for the answer. Can anyone tell me what is the treatment for LADA? What do you want to give? It's a latent autoimmune diabetes of adults. So you have to give, right? You have to give insulin in these individuals. Right? The treatment in these individuals is insulin has to be given. Right? Why? Because there is autoimmune destruction of the beta cells. So once there is an autoimmune destruction of the beta cells, there is no insulin. So insulin is reduced in these individuals. So insulin will be the treatment of choice in these individuals. Right? Insulin will be treatment of choice in these individuals. So just please give me a thumbs up if you have understood this clinical question. So just please give me a thumbs up if you have understood this clinical question, and let me know whether I am going fast or the speed is adequate. Am I going very fast? The speed is adequate? Right? Am I going very slow? What is that, you tell me? Very good. So I'm happy that everyone is understanding the questions. Okay, Acha, Dr. Mohan, thank you. Adequate. Okay, right. Fine. Now let me just move on to the next question. Right? Let me just move on to the next question then. Okay, so if you take the next question, we have a 50-year-old Asian man is referred to the diabetic clinic, right? Is referred to the diabetic clinic after presenting with polyuria and polydipsia. He has a BMI of 30, a blood pressure of 137 by 88 millimeters of mercury, and a fasting plasma glucose of 7.7 millimoles per liter. The most appropriate first-line treatment is dietary advice and exercise, sulfonylurea, exenatide, thiazolidinediones, metformin. What is the first-line treatment in these individuals? So you see here, the patient is having 7.7 millimoles per liter, which one fasting. So that is nearly around 136 milligrams per deciliter. Now, what is the cutoff? Okay, so, and let me see how many of you have answered. Only Adarsh Soni has answered, and now Shankar Deepu has answered. Excellent. I really appreciate both of you, Shankar Deepu and as well as Adarsh Soni. Right? So the patient is having the fasting blood glucose of 136. Now, what is the cutoff of fasting? The cutoff is fasting more than, right? Fasting more than 126 milligrams per deciliter. That is what is considered as diabetes mellitus. So Once the individual has been diagnosed for the first time, the first line treatment is the dietary advice and exercise. So this is the answer to this particular question, that is dietary advice and as well as exercise. Now let me explain you why. See, in the management of diabetes mellitus, right, first you should advise exercise. Now why you should advise exercise? Why? Because on doing exercise, there will be increase in the insulin receptors on the skeletal muscles. Right? There will be increase in the insulin receptors on the skeletal muscles. Okay. So once there is increase in the insulin receptors in the skeletal muscles on doing exercise, what will happen? The glucose will enter into the muscle. And thereby, there will be adequate glucose control. Right, thereby there will be adequate glucose control. Right, so that is the purpose why you should advise the exercise in this patient. Right, now even on doing exercise, right, upon doing exercise and maintaining proper diet, that is carbohydrate restricted diet. So upon doing all this, if the blood glucose is still high, right, if the blood glucose is still high, that is the point when you need to advise oral hypoglycemic agents. And within the oral hypoglycemic agents, for type 2 diabetes mellitus, drug of choice is metformin. Right, drug of choice will be metformin. Okay, so that is the answer to this particular question. Right, so going back to the question again. So dietary advice and exercise, sulfonamide, and he's a 50-year-old Asian man. 50-year-old Asian man means obviously it will be type 2 diabetes mellitus. Right, so dietary advice and exercise, and if not, then you can give metformin. Right, if not, you can give metformin. Okay, so the answer to this particular question is the first option. Now, once after having discussed about the treatment of type 2 diabetes mellitus, now we will move on to the next important clinical question. So can anyone tell me, like, how do you feel is the quality of the questions? So do you feel that these are the questions that can appear in your FMGE exam? Because some of you have written the FMGE exam on August 31st. So I hope the questions, the quality and as well as the strength of the questions were similar to that of like what you had in your exam. Okay, now, yes, so thank you very much. Then we will move on to the next question. Right, so yes, Sharad, I will definitely post all these questions in the group. I will send to Arise Medical Academy staff. So if you are students of Arise Medical Academy, you will be getting these questions. I'll be sending to the staff of Arise Medical Academy yesterday's questions and as well as today's questions. Both of them, I'll be sending them. So I will ask them to put them in your respective Arise Medical Academy, either Telegram group or WhatsApp group, whatever it is. Okay, so you see the next question. We have a 55-year-old diabetic woman presents with altered sensorium, sorry, not altered sensorium, altered sensation in her hands and feet. She finds it difficult to put to turn pages of books and discriminating between the different points. When walking, the floor feels different, and she likens the sensation of the walking on the cotton wool. What is the most likely diagnosis in this patient? Autonomic neuropathy, diabetic amyotrophy, acute painful neuropathy, symmetrical sensory neuropathy, diabetic mononeuropathy. So what is that you think is the answer to this particular question? Yes, who will be the first one to answer this question? Very good. So again, GA and as well as Santhia Ver, right? And now Bala Ashokan. So you have answered this question. Very good, Shankar Deepu. So the answer is symmetrical sensory neuropathy. The answer is symmetrical sensory neuropathy. Okay. Now, why is that? And everything I'll explain. So she's a diabetic patient. So in diabetes mellitus, you have certain chronic complications. And what are the chronic complications in diabetes mellitus? You have macrovascular complications and you have the microvascular complications. Both are there, both macro and as well as micro. Now, what are these macrovascular complications? The macrovascular complications, what you will have is coronary artery disease, cerebrovascular accidents, peripheral vascular disease. Right, peripheral vascular disease. So coronary artery disease, cerebrovascular accident, and peripheral vascular disease. So these are the macrovascular complications. And microvascular complications are diabetic neuropathy, diabetic nephropathy, right, and diabetic retinopathy. Right, diabetic retinopathy. So these are the microvascular complications. Now, out of that, what does this patient has is diabetic neuropathy. Now, let me explain you about the diabetic neuropathy. So, if you take this diabetic neuropathy, what is the most common type of the diabetic neuropathy? The most common type of diabetic neuropathy in diabetes mellitus is, it is distal symmetrical sensory neuropathy. Right, distal symmetrical sensory neuropathy. This is the most common type of the diabetic neuropathy. Now, what will be the clinical manifestations in case of your distal symmetrical sensory neuropathy? They will have altered sensations in the extremities. Right, they will have altered sensations in the extremities. Right, what is that altered sensations? These altered sensations are tingling and numbness in the fingers, tingling and numbness in the lower limbs, and they will have that burning sensation within the feet. Right, that is nothing but your altered sensations. Okay, now our patient has the same thing, and because of this particular peripheral neuropathy, whenever the individual walks, the individual feels that he is walking on a cotton wool. Right, whenever the individual walks, the individual feels that he is walking on a cotton wool. Right, why is that? That is again because of your diabetic neuropathy. Now, the point is you should understand what should be the treatment given in these individuals. Can anyone tell me what is the treatment you give for this particular altered sensations in diabetic neuropathy? Any one of you, please? So the treatment what you need to give is duloxetine. You can give the other important drugs. That is pregabalin. Then followed by that amitriptyline, then gabapentin. So these are the treatment options which are available for diabetic neuropathy. Okay, right. And this duloxetine, you can consider it as drug of choice. Right, duloxetine is considered as the drug of choice. Okay, now we will move on to the other options. We will move on to the other options. See, always in a clinical question, you should be able to rule out the other options also. Right, you should be able to rule out the other options also. Now let me rule out the other options. And now you take diabetic amyotrophy. See, in diabetic amyotrophy, what will be the clinical manifestation? In diabetic amyotrophy, please remember this. They will have proximal muscle weakness. Right? They will have what is called proximal muscle weakness. That is the feature of your diabetic amyotrophy. And because of this proximal muscle weakness, the individual is unable to get up from sitting position. See, in diabetic amyotrophy, this will be the clinical manifestation where the individual is unable to get up from the sitting position. In diabetic amyotrophy, you will not have that altered sensations in the hands and feet. That is completely against your diabetic amyotrophy, right? Against your diabetic amyotrophy. And these individuals will, because there is proximal muscle weakness, they are unable to climb, right? Unable to climb the steps. Right, they are unable to climb the steps because of the that will be the manifestations in proximal muscle diabetic amyotrophy. So that is not there. So your diabetic amyotrophy is ruled out. Right, diabetic amyotrophy is ruled out. Now you take the autonomic neuropathy. Right, you take this autonomic neuropathy. The classical clinical manifestation in autonomic neuropathy is postural hypotension. Right. So in autonomic neuropathy, the classical clinical picture will be the postural hypotension. So does this patient has the postural hypotension? No. So that is the reason why your autonomic neuropathy is also ruled out. Right? Then, now the other point is acute painful neuropathy. Acute painful neuropathy is not at all the manifestation, because acute painful neuropathy, they present acutely. That means abrupt in onset, and these individuals, they will not have the altered sensations in acute painful neuropathy. In acute painful neuropathy, these individuals will have severe pain in the limbs. That is not there in your question. So that is the reason why your acute painful neuropathy is ruled out. Now, you take diabetic mononeuropathy, right? Diabetic mononeuropathy. It is not diabetic mononeuropathy also. Why? I'll tell you. See, what are the various ways by which your diabetic mononeuropathy can present is, there can be median nerve neuropathy, where the individual will have carpal tunnel syndrome. The individual can be ulnar neuropathy. The individual can have tarsal tunnel syndrome, where there is compression of the tibial nerve. Right? TTS, tarsal tunnel syndrome. So that is not there in your patient. Right? So your diabetic mononeuropathy is ruled out. What is mononeuropathy? Single nerve is compressed. The clinical manifestation pertaining to single nerve. Is that there in your patient? It is not there. So that is the reason why your diabetic mononeuropathy is also ruled out. So that is the answer in this particular question is the symmetrical sensory neuropathy. Now, I wanted to ask you one important question at this stage. Can anyone tell me what is the most common cranial nerve which is damaged? What is the most common cranial nerve affected in diabetes mellitus? Yes, who will be the first person to answer this question to me? What is the most common cranial nerve damaged in these patients with the diabetes mellitus? Yes, who will answer this question to me? No, not optic nerve, not optic nerve. नहीं, everyone is, अरे क्या बात कर रहे हैं? हाँ, optic nerve, vagus, trigeminal. No. The most common cranial nerve which is affected in diabetes mellitus is oculomotor nerve. Right? Oculomotor nerve. Okay. So that is the third cranial nerve. That is the third cranial nerve which is being affected. Right? Yeah. So the answer is the oculomotor nerve. So now going back to the question again, what is the answer here? The answer is symmetrical sensory neuropathy. The answer here is symmetrical sensory neuropathy. So with this, let me just conclude this particular session, right? So please give me a feedback of the session so that it will help us to improve further. So please feel free to give the feedback. So that will definitely help us to deliver you the best. And in the upcoming sessions, we will be also doing instruments in general medicine. We will be also doing image-based questions in the general medicine. So that I will be planning in the next month. This month, exclusively the clinical-based questions on cardiology. Sorry, clinical-based questions on endocrinology. Next month, as I have already said you, that we will be doing the clinical-based questions on neurology, cardiology, and pulmonology. Right. And okay. Right. So with this, I will just wind up this session, and tomorrow again, the session will be at the same time. Acha, Santhyavir, you want almost like 10 to 15 questions per day. Like what happens is, acha, questions can be little tricky, okay? Right? Thank you, Shankar Deepu. But Santhyavir, what will happen is, yeah, from tomorrow onwards, I'll try to do more questions. Because these are clinical based questions, I am unable to cover more questions, but from tomorrow onwards, definitely I'll try to do more number of questions. Okay. So again, tomorrow, the class will be, the live session will be at the same time, that is 7 p.m. Right? And please inform to all of your friends also. Right? Let everyone take the advantage of these live sessions. And these are the ones which are going to appear even in your FMGE exam. Okay. So with this, I will just conclude this particular session and see you tomorrow again at 7 p.m. Yeah. Okay. IAM, definitely I'll take up the questions on cirrhosis of liver, like hepatitis, portal hypertension. I will discuss. Definitely I will discuss. When I am doing gastroenterology, definitely I'll discuss. Right. Yeah, fine. I'll try to balance. I'll try to balance. Okay. But definitely I will teach you how to rule out the other options. Yes, Pavan Kumar. Definitely I'll teach you how to rule out the other options also. I'll try to balance both. I'll try to increase the number and I'll try to balance to see that I will try to rule out the other options as well. Okay. So thank you very much and see you tomorrow again at 7 p.m. And please inform to your friends as well. Let everyone take the advantage of these particular sessions. Right. So thank you very much. Good night. See you tomorrow again.